and that will be dealt by Dr. Rohit Sashidharan. He is now currently Assistant Professor in the Department of Neonatology, AIIMS Guwahati. I will request Dr. Bijan to say few words regarding the high frequency ventilation in the neonates. After finishing the Bijan's initial introduction, Dr. Rohit will start the session, and at that time, more delegates will come into the online. Please, Bijan, go ahead.
Thank you, sir. Good evening, everybody. As rightly said, today we have got the 11th lecture of our series. And before this lecture, we have already completed physiology of respiration, lung mechanics, blood gas, how to interpret different knobs in basic modes of ventilation, volume guarantee ventilation, then non-invasive positive pressure ventilation, etc. So what basically we have done before this high frequency ventilation, we have actually discussed about basic modes of ventilation or conventional ventilation. But over the years, high frequency ventilation in neonate is increasingly used by the clinician. One of the most important thing what happens in high frequency ventilation is that you recruit the lung with high MAP without causing lung damage. As we have already known, whatever ventilation you do, there will be some kind of trauma to the baby's lung, especially in preterm infants that may lead to bronchopulmonary dysplasia. One of the important strategy or recruiting more and more alveoli and for better gas exchange without causing much damage to the baby's alveoli, the strategy is high frequency ventilation in neonates. I don't know how many of you are using high frequency ventilation in newborn, but many units are using as a primary mode or as a secondary mode. In some Western countries, some countries like Scandinavian countries, they are using this as a primary mode of ventilation with the idea that whenever you are ventilating a baby, you have to recruit more and more alveoli, or there is uniform distribution and delivery of the gas across the alveoli. Once there is uniform distribution and of the gas across the alveoli, there will be better gas exchange. And one of the most important thing that all of you might be knowing, you are ventilating a neonate less than the dead space volume. So you are having more and more MAP without causing lung damage. That is the beauty of high frequency ventilation in neonates. There is so many things regarding this high frequency ventilation in neonates. I am not going to speak in details because we have got Dr. Rohit. As Sir has already said, Rohit is a DM from AIIMS Jodhpur. Currently, he is Assistant Professor of Neonatology at AIIMS Guwahati. He is an excellent speaker, young, dynamic speaker. I'll request Rohit, please start your talk now. Rohit, Rohit, now the floor is yours.
Okay.
Thank you.
So, good evening, everybody. So, thank you, sir, for the introduction to the topic and my introduction. So, first of all, I want to thank the organization for giving this opportunity. And I can see that this is a very wonderful initiative, and all the topics have been very thoughtfully arranged and sequentially arranged. And as sir has already discussed, we have covered a lot of basic ventilation, non-invasive ventilation, even disease-specific ventilation. And there might be some situations where we come across where we are not able to manage the babies on conventional ventilation. So over the next 30 minutes or so, I hope that I'll be able to discuss some of these babies whom we can use high frequency ventilation. So my objectives will be to give a brief introduction to high frequency ventilation, try to understand its physiology and the mechanism of action, what are the different clinical indications when we start, how to initiate, monitor and wean, and a brief recap on the evidence of high frequency ventilation. So by definition, high frequency ventilation, it is defined as a group of ventilatory technique that utilize, there are three basic characteristics for a high frequency ventilation. So one, it utilizes supraphysiological rates. So we know that in conventional ventilation, your rates of ventilated rates are usually varying from 40 to 60. So when it comes to high frequency ventilation, we are using supraphysiological rates. So the rate can vary from 300 to 3000 breaths per minute, or in other words, 5 to 50 hertz. So 1 hertz is equal to 60 breaths per minute. The second characteristic feature is we are using very small tidal volumes, like from 1.5 maybe 2 or maximum 2.5 ml per kg. So this tidal volume is actually less than the dead space volume. And the third characteristic feature is both inspiration and expiration is active. So any ventilation technique which uses all these three principles can be labeled as a high frequency ventilation. So what are the advantages of high frequency ventilation? So as Sir has just discussed, it allows us to deliver high pressures with minimal lung injury. So we know that there are situations where we'll have to give high pressures, especially when there is a lot of lung collapse and we want to recruit the lungs. So when we want to optimize the PEEP and optimize and have an optimal functional residual capacity, invariably we'll have to provide high pressures. So what happens with conventional ventilation is when we provide high pressures, it is usually associated with a lot of trauma. You can have barotrauma, volutrauma, atelectotrauma, the shear trauma which happens with opening and collapsing of alveoli. All of this will ultimately lead to ventilator-induced lung injury. So high frequency ventilation is a magical mode of ventilation which allows us to recruit the lungs with high pressures, but there is minimal lung injury. So one reason is that we are using very small tidal volume, and we know that volutrauma is always more dangerous than the barotrauma. So by using this principle, it also helps to reduce the air leak and as well as chronic lung injury. So there is sufficient evidence which shows that if you use high frequency ventilation, then the incidence of chronic lung injury, that is the BPD, is also decreased. And another important advantage of high frequency ventilation is that we are able to independently regulate the oxygenation and ventilation. So in conventional ventilation, we know that the gas exchange is predominantly based on the alveolar ventilation. And for CO2 retention, we equate it to minute ventilation. So minute ventilation in turn is a product of tidal volume and the respiratory rate. So invariably, whenever we try to fiddle with the tidal volume by either increasing the PIP or by decreasing the PEEP, we are invariably going to affect the MAP. So if we increase the PEEP, then the MAP is going to increase, and then ultimately it can cause hyperoxia. On the other hand, if we decrease the PEEP, then it will decrease the MAP, and then it can cause hypoxia. So in conventional ventilation, both oxygenation and CO2 removal is interlinked. But when it comes to high frequency ventilation, we can independently manage both of these. So we'll come to the details in the subsequent slides. So why small volumes? So high frequency ventilation, it allows gas exchange to happen with small volume displacement. So in this way, we are able to actually decrease the volutrauma. It allows us to deliver the optimal PEEP. And this optimal PEEP is required to recruit the alveoli and prevent the atelectasis. And in a way, it helps in optimizing the ventilation perfusion ratio. So this principle is known as open lung ventilation or lung protective ventilation. So high frequency ventilation is one mode which helps us to achieve this. So how it works? If you look at the conventional ventilation, we know that the normal tidal volume it varies from 4 to 6 ml per kg, and the anatomical dead space is around 1 to 1.4 ml per kg. So in conventional ventilation, the principle is direct alveolar ventilation. So it is defined as tidal volume minus the dead space into the respiratory rate. But in high frequency ventilation, we know that the tidal volume is less than the dead space. So if you apply the same principle, we can see that the alveolar ventilation is 0. So this indirectly tells us that the mechanism of action in a high frequency ventilation is different from that of a conventional ventilation. So we cannot expect the baby to have direct alveolar ventilation in a high frequency ventilation and maintain the oxygen and saturation and the CO2, because Here we are dealing with very small tidal volume, which is even lesser than the anatomical dead space. So if you look at the commercial available ventilators, there are a lot of ventilators which provide high frequency ventilation. They can be classified as hybrid ventilators, which typically have piston oscillators, and they provide both conventional ventilation and high frequency ventilation. So in a way, it is advantageous. Like if a baby is on conventional ventilation, it is easier for us to shift to high frequency ventilation. And on the other hand, when the baby is improving, it will be easier for us to shift back to conventional ventilation. But there are other ventilators which are like standalone high frequency ventilation. And one such example is the sensor MEDX. It is also known as a membrane oscillator. So these have, instead of piston, we have large loudspeaker like membrane oscillators. So here is the membrane, and the oscillation of the membrane is going to cause active inspiration and expiration. The advantages of this is these are very powerful machines, and they can be used for even bigger babies and pediatrics also. But they can cause a lot of sound pollution and vibration, and there are some concerns with neurodevelopmental impact of these ventilators. So to classify the high frequency ventilators, they can be classified as high frequency positive pressure ventilation, high frequency jet ventilation, and the high frequency oscillation. So we are most commonly dealing with high frequency oscillation in our settings, and the other two, jet ventilation and high frequency positive pressure ventilation, are rarely used. So what is high frequency positive pressure ventilation? It is actually a modification of the conventional ventilation system with using certain dedicated tubings with small internal compressible volumes. We are providing higher rates. So conventional ventilation, we rarely go beyond 60 breaths per minute. So in high frequency positive pressure ventilation, we give a higher breath rates from 60 to 150 per minute. We use higher flow rates and smaller tidal volume. So these are some of the ventilators, like the Drager VIP log ventilator, baby log ventilator. They use a modified high frequency positive pressure ventilation. This is a classical example of the high frequency oscillatory ventilation. Just we have seen in the few slides ago, where we have a membrane oscillator which oscillates, and that can cause the displacement of air. But there are other devices which are piston devices or which have some jet reverse flow mechanism, which also helps in providing high frequency oscillator ventilation. This is a high frequency jet ventilation system. So this is the Bunnell life pulse ventilator. Here we have a unique ventilatory assembly which helps to provide an additional intermittent high frequency jet ventilation. So in addition to the conventional ventilation, we are able to provide some high frequency jets of flow, and that helps in oxygenation and ventilation. So to summarize, high frequency oscillatory ventilation, it can be by a piston or other means such as diaphragm. The IE ratio is typically 1:1 to 1:2. The optimal frequency is 8 to 15. Some of them will allow to provide a superimposed sigh breaths. Now, sigh breaths are like superimposed conventional mechanical ventilation, usually at a slightly higher pressure than the conventional mechanical ventilation, at a rate of maybe 3 or 5 breaths per minute. So these can help to recruit the alveoli and also prevent the collapse of alveoli. So some ventilators like Babylog, SLE, they allow sigh breaths, and the sensor MEDX ventilator does not allow sigh breaths. Now, high frequency jet ventilation, they have a unique pinch valve or injector cannula. Here we provide intermittent ventilation in addition to the conventional ventilation. So the IE ratio is 1:4 to 1:8. The ideal frequency is 5 to 8, and here also we are able to provide sigh breaths. In high frequency positive pressure ventilation, and similar mode is high frequency flow interrupter, there also the IE ratio is 1:3 to 1:6. The frequency in high frequency flow inflator interrupter is similar to that of high frequency oscillator ventilator, but high frequency positive pressure ventilation has a very low frequency. It varies from 1 to 2.5, that is similar to 60 to 150 breaths. Now, what is the mechanism of action of HFO? So as discussed previously, it is different from that of a conventional ventilation. But however, some of the proximal alveoli, which are very close to the central airways, they can have direct alveolar ventilation, just like in case of a conventional ventilation. So other mechanism which help in ventilation are, we have mechanism like asymmetric velocity profile. So when you see an inspiration, we can see that there is differential velocity. The central part of the inspiratory flow will have higher velocity when compared to the peripheral part. So the air flows in a conical pattern. While on the expiration, being a lower velocity, it is uniform, and because of this asymmetry in the inspiratory and expiratory velocity, generally the inspiratory air tend to go through the center and the expiratory goes to the periphery. So it is proposed that because of this, the exchange can occur in the boundaries of the inspiration and expiration. Another mechanism which is commonly used to explain this is the pentaleft phenomenon. So we know that there are different alveoli units and they have different inspiration, different time constant. That is, the compliance and resistance of different alveoli units are different. So the time constant, that is the time required for filling, is also different. So some of the alveoli may be in a filling phase, while some of them may be in an emptying phase. So because of this variation, it is possible that one alveoli which is getting emptied is going to fill the next alveoli. So this phenomenon is known as pentaleft phenomenon. This can also help in gas exchange. There are other mechanisms like turbulent flow, radial mixing, diffusion, and even collateral ventilation. These are some of the proposed mechanisms which can explain gas exchange in high frequency ventilation. Sometimes because of the cardiac beating, heartbeat, then there can also be some mixing of gases. So this is an example of Taylor dispersion where you can see the conical pattern, and at areas of where there is bends or any obstruction, there will be generation of turbulent flows, and this can cause creating something known as eddy currents. All of this will help in gas exchange. And this is the pentaleft phenomenon where an alveolar unit which is emptying is going to ventilate the surrounding neighboring alveolar unit. So this happens because of the variation of time constants of different alveoli. So what are the indications and how do we use high frequency ventilation? When do we use high frequency ventilation in clinical practice? So conventionally, we are using in as a rescue mode and typically as a late rescue mode. So whenever the babies are failing on a conventional ventilation, then we switch to high frequency ventilation, and that is the most commonly used mode of ventilation. Another indication is early rescue. So these are typically indicated in infants which have high risk of complication with conventional ventilation. So we'll come to see the examples of a few examples of these. And in certain units, as Sir has discussed, even high frequency ventilation is used as a primary mode of ventilation. So this is especially common in the Scandinavian countries where even preterm babies, 23, 24 weeks, are straight away started on high frequency ventilation. So since these babies are at high risk of BPD, using a lung protective ventilation by optimizing the lung volume, by recruiting the lungs, they are proposing to decrease the BPD and other complication. So even though the evidence is not very convincing and there are a lot of controversies, but there are units which are using high frequency as a primary mode of ventilation. So if you see the late rescue, like any condition where the conventional ventilation fails, whether it is RDS, where it is pneumonia or PPHN or meconium aspiration, we do consider high frequency ventilation. In early rescue is certain conditions where conventional ventilation is causing much more damage. For example, in the presence of pulmonary air leaks. So if there is an already existing PIE or a pneumothorax, if you continue on conventional ventilation, it is going to cause more damage. Or in setting of pulmonary hypoplasia, where there is a low volume lung, then we can consider HFO higher up or pretty early. Or any condition where there is chest wall movement restriction. So it may be because of hydrops, it may be because of post-op patient or a baby with gastroschisis or omphalocele. So these are some of the indications where we consider starting high frequency much earlier than when the baby fails. So the common established indication is in the presence of PIE or air leaks, when there is severe respiratory failure which is refractory to conventional ventilation, situation where with abdominal or chest wall restriction, in pulmonary hypoplasia, and in PPHN as an adjunct to INO. So coming to the definition of ventilation failure, for preterm babies, we consider that whenever the PIP is going more than 22 or 25, we may consider starting high frequency ventilation. And in a term baby, it is said that when the PIP is reaching somewhere around 25, that is an indication for starting high frequency ventilation. So generally, if we wait for the baby to completely collapse and then start high frequency ventilation, then you are usually too late. In such situation, it's like a shortcut. You won't be able to save the baby. But if you use high frequency ventilation optimally a bit early, then you'll be able to do wonders with high frequency ventilation. So it should not be used as a last resort, like when nothing is working, then we switch to high frequency ventilation. It has to be used judiciously. When we see that the baby is not improving, the pressures are building up, and we need pressures beyond 20, 22, or the maps are going beyond 10 or 12, then we should switch to high frequency ventilation pretty early. So what are the different variables? So in conventional ventilation, we must have discussed about the 6 players: PIP, PEEP, FiO2, the respiratory rate, IE ratio. But when it comes to high frequency ventilation, we have 5 parameters. The MAP and FiO2 is typically used to control the oxygenation part, and the CO2, the amplitude and frequency, is typically used to control the ventilation part. So MAP and FiO2 will help in oxygenation, and amplitude and CO2 help in controlling the CO2. IU ratio is usually fixed. We don't usually fiddle with the IU ratio. It is usually set as 1:1 or 1:2. So oxygenation. So in order to oxygenation, the first step will be to provide adequate MAP to make sure that the recruitment is appropriate, and then titrate the FiO2 as per the saturation target. So this is the same principle whether we use delivery room CPAP or whether we use conventional ventilation. Our main aim should be to optimize the FRC and optimize the PEEP, so that more and more alveoli are recruited and the work of breathing decreases and the gas exchange improves. So once we optimize the FRC, then we'll be able to have a good ventilation perfusion ratio. There will be decreased shunting, and we'll be able to have a good gas exchange. So same principle should apply to high frequency ventilation also. So for example, if you're starting high frequency ventilation as a first intention approach, that means as a primary mode of ventilation, we start somewhere between 6 to 8 centimeter of MAP. And when we use as a rescue mode, that is switching from conventional ventilation, we typically start from 2 or 3 MAP above that of the conventional ventilation. So it is very important to note the MAP of conventional ventilation before switching to the high frequency ventilation. So even in conventional ventilation, we need a PEEP of 7 to 8 to obtain an optimal FRC. But in certain situations like pneumothorax, pulmonary hypoplasia, congenital diaphragmatic hernia, we generally start at a MAP which is equal to that of a conventional ventilation. And in all conditions like hyaline membrane disease, pneumonia, PPHN, we generally start at a MAP which is 2 to 3 above the what is there in the conventional ventilation. Another factor which you have to take into account is when there is hypotension, like in the presence of hypotension or cardiac instability, if you keep on increasing the MAP, then it is possible that the baby might worsen the hypotension. So there we might have to reduce the MAP by 1 or 2. And generally, we first thing to wean will be the FiO2. So we'll come to that in the subsequent slides. In some units, some people are comfortable using the recruitment maneuver. This is usually done in homogeneous lung conditions like RDS. So here we start at a MAP of around 2 centimeter above the conventional ventilation. Then we gradually keep on increasing the MAP in steps of 1 to 2 till the oxygen starts improving. And once the oxygen starts improving, it goes beyond 95, we can start decreasing the we'll keep on increasing the FiO2 till the FiO2 starts dropping. So then once we taper the FiO2 by 5 to 10, once it reach below 0.3 or 0.25, this means that now the lungs are fully recruited. So this is known as the opening pressure. And once we have reached the opening pressure, then we start reducing MAP by 1 to 2. So after some time, we can see that the SpO2 starts falling, and this is known as the closing pressure. So generally, it is advised that we can keep a MAP 1 to 2 above this level after recruiting the lung again. So this is the graphical representation of the recruitment maneuver. So this is the starting pressure, which is usually almost same as that of the conventional mechanical ventilation. We gradually increase the pressure by 1 to 2 of MAP, and at one point we'll see that the FiO2 has gradually come down as the more and more lungs are getting, alveoli are getting recruited. The oxygenation is going to improve, and we'll be able to taper the FiO2 to somewhere around 0.3 or 0.25. At this point, we have reached the opening pressure. Now we can gradually decrease the MAP, and at one particular point, we can again see that the saturation starts falling. So this point of C is known as the closing pressure. So then it is advised to recruit the lung again and then keep at point E, which is 1 to 2 centimeter above the closing pressure. So this is a mode of recruitment, but many units are not using recruitment. This is done only those units which are doing high frequency on a regular basis and are very comfortable. But conventionally, what we do is whatever is a MAP on the conventional ventilation, we can start at 2 or 3 above that level, and then we can titrate upward based on the SpO2 and other parameters. So when it comes to oxygenation, so in the presence of hypoxia, the first aim will be to recruit. So that means we can increase the MAP. We have to gradually increase the MAP. Maybe if the starting is 12, we keep on increasing by point every 2 or 3 till we see that the oxygenation has improved. Another additional method which we can consider to improve the oxygenation is adding a sigh breaths. So these are sort of sustained inflation breaths, usually at a higher pressures than the conventional ventilation. Suppose on conventional ventilation the PIP was 20. Here we keep a PIP of maybe 25 or something. So these two maneuvers can help in recruiting more alveoli and help in increasing the FiO2. In the presence of hyperoxia, our primary aim should be to come down on the FiO2 first. And once the FiO2 comes below 0.5, then we can consider gradually decreasing the MAP. Now, in high frequency ventilation, the CO2 elimination depends on the diffusion coefficient of CO2. So predominantly it depends on the oscillatory volume. So in conventional ventilation, we know that CO2 elimination is based on minute ventilation, which is a product of tidal volume and frequency. But when it comes to high frequency ventilation, CO2 elimination depends on diffusion coefficient of CO2, which is tidal volume square into frequency. So oscillatory volume has a major role in CO2 elimination compared to that of a conventional ventilation. So if the oscillatory volume is more, then the more will be the CO2 elimination. On the other hand, frequency has an inverse relation compared to that of a conventional ventilation. So what is amplitude? So it is defined as the variation around the MAP. So if you see, if this is the MAP, then the variation around the MAP is defined as amplitude, and it indirectly determines the oscillatory volume. So some ventilators, it denotes amplitude as a percentage from 0 to 100. So 100 being maximum percentage of displacement which is possible for that particular setting, or while some ventilators give an absolute number. So generally, two factors which determine the amplitude is the MAP and frequency. And typically, one way to, in the beginning when we start ventilation, one way to set the amplitude is you start at twice the MAP. Suppose we are starting at a MAP of 12, we can put an amplitude of 12 in the beginning, 24 in the beginning, and you titrate based on the wiggles. Wiggles is a vibratory movement of the chest and abdomen. So we have to have a vibration which is visible till the umbilicus. So this is one method to optimize your amplitude in the beginning. Subsequently, we'll have to take help of other parameters like blood gas and chest X-ray and CO2 to optimize your amplitude. So in frequency, we have already discussed that tidal volume is proportional to the frequency. So if the frequency increases, the minute ventilation increases. But in high frequency ventilation, the tidal volume is inversely proportional to frequency. So as the frequency decreases, the stroke volume of each oscillatory volume is increasing. So we'll come to that in the subsequent slides. So generally, lower frequency means you'll get sufficient time for more tidal volume to exchange. For example, here we can see that in the lower graph, the frequency is quite high. Because of this, there is little less time for the tidal volume. On the other hand, as the frequency decreases, we can see that there is sufficient volume, sufficient time for tidal volume. And as we have seen in conventional in high frequency ventilation, the gas exchanges, CO2 exchanges, depending on the square of tidal volume. So lower frequencies have higher volume displacement and hence more CO2 elimination. So how to decide on the frequency? So 10 is a good number to begin. So if you don't know anything, it is very safe to set a frequency of 10. But general principle is that optimal frequency is the frequency that causes the best ventilation with lowest tidal volume and lowest amplitude. So there is a concept called resonating frequency for each lung. It depends on the patient size. For example, smaller the baby, higher the frequency will be the resonating frequency. Smaller, shorter the time constant, higher the frequency. So generally, for a preterm baby, we may give a higher frequency. On the other hand, for a term baby with meconium aspiration or a bigger baby, we can consider a lower frequency. But conventionally, we don't fiddle with the frequency unless other parameters are changed first. So let us see how amplitude and frequency is going to affect your CO2 elimination. So suppose this is the baseline and this is the amplitude and this is the frequency. So with this amplitude and frequency, we can see that this green is the stroke volume. So if you want to increase the ventilation, that is thereby increase the CO2 removal, if you increase the amplitude, so we can see that now the amplitude is doubled and it will cause an increase in stroke volume or the oscillatory volume. So that is one method by which we can eliminate CO2. And that is the first method that we should try. The second method is to decrease the frequency. So once you decrease the frequency, then also you can see that the stroke volume is improving. So these are the two methods by which we do CO2. We want to, is a method for washing out CO2. So on the other hand, if we want to decrease the ventilation and suppose there is already a hypocapnia, then the first method will be to decrease the amplitude. So here we can see that once you are decreasing the amplitude, then the stroke volume is getting decreased. And if that fails, then we can consider maybe increasing the frequency. So when you increase the frequency, then the time for displacement will be less and the lower will be the stroke volume. So these are the strategies by which you control the CO2 in high frequency ventilation. So when there is hypercapnia, then first we increase the amplitude. And if that is not working, then we can consider decreasing the frequency. On the other hand, in the presence of hypocapnia, first step will be to decrease the amplitude. And if that is not working, then we can consider increasing the frequency as a last step. What about inspiratory time? It is usually fixed at 33%. That is IE ratio of 1:2. But there are certain situations when there is problem with oxygenation, we can consider 1:1. There are certain newer modes in high frequency ventilation, that is high frequency volume guarantee. But even though it is promising, right now it is predominantly used as in experimental mode, especially in research settings. So we know that even apart from the volume per se, it is the fluctuation in tidal volume that also causes volume trauma. So by having a volume guarantee function, it helps to decrease the tidal volume fluctuation. And by this way, it can also decrease those situations where the CO2 is gone varying, like hypocapnia and hypercapnia episodes and the episodes of hypoxia. So here we set a targeted tidal volume and the ventilator will change the amplitude to achieve that set tidal volume. So that is one method which can ensure that the tidal volume is uniform and there is less fluctuation in tidal volume. So this is useful, especially in rapidly changing respiratory dynamics. But currently, we are not using it routinely unless in some research settings. So these are some of the ventilators which offer this option of volume guarantee. So this is the Drager VN500. This is the Fabian Accutronics. Here also there is an option for volume guarantee. And even this SLE 6000 also offers this option of volume guarantee in high frequency ventilation. So, so these are some of the conditions which you come across. Suppose there is overinflation as detected clinically, or in an X-ray which is showing hyperinflation with rib space which is visible more than 9, with flattening of diaphragm, or the liver is pushed down, then we might have to decrease the MAP. Otherwise, there is high chance of air leaks. Suppose the baby is having hypotension and there is tachycardia and low BP, then we might have to consider decreasing the MAP. So how do you monitor a baby on high frequency ventilation? So first thing will be clinical. So as soon as you put the baby on high frequency ventilation, you have to be bedside and we have to see what is happening to the saturation, what is happening, how do we titrate, what is happening to the chest wiggles and vibrations, till whether it is visible till the abdomen or not. At the same time, we have to take a look at the vitals also, look at the blood pressure, look at the heart rate, and what is happening to the capillary filling time. We can take use of non-invasive methods like, if available, apart from SpO2, if we have an EtCO2, that can help in decreasing the number of blood gases. But once the baby is stable clinically, then we'll have to do a blood gas, and we have to see calculate what is the PO2, what is the CO2, what is the oxygenation index, and then titrate appropriately. It is generally advised to get a chest X-ray within 30 to 60 minutes of starting high frequency ventilation. So this will tell us about the recruitment status, whether lungs are appropriately recruited or not. Our target is to have a lung expansion of 8 to 9 reps. So if it is less, then we might consider increasing the MAP. Some other precautions which has to be done as part of nursing care in high frequency ventilation is we have to avoid frequent disconnection. So whenever we disconnect the ventilator, maybe for suction or maybe for other purpose, then it will cause de-recruitment and the baby can again worsen. So then it takes some time for the alveoli to recruit again, and then for the saturation and everything to pick up. So till the baby is stable, it is better to avoid frequent disconnection. Suctioning has also to be done judiciously. So whenever we disconnect for suction, the same thing can happen. And if you do vigorous suction, there is always chance of more collapse, because here we know that the expiration is also active. So in super added to that, if you do suction also, then it can sometimes cause collapse. And it is very important that we take care of humidification, because if you don't humidify while providing high frequency ventilation, it can lead to necrotizing tracheobronchitis and other complication. So blood gas is recommended in the beginning once the baby is stabilized, and subsequent will be based on clinical status. And if you have made a major setting change, then we can do it after 20 to 30 minutes after a major setting change. One way to decrease the use of ABG is there is a parameter called diffusion DCO2. It is usually visualized or visible in some of the ventilators. So if you keep a track of the DCO2, that will indirectly give us an idea of the ventilation and the CO2 elimination. So tracking the DCO2 can in a way decrease the number of blood gases which need to be performed. X-ray is typically done after 1 hour after initial stabilization to identify whether the recruitment is appropriate or not. What about weaning? So once the baby is stabilized, the first thing to wean will be the FiO2. If the baby is on very high FiO2, more than say 80% or 100%, so as soon as the baby is recruited, the MAP is optimized, then we have to start titrating the FiO2. So once the FiO2 becomes less than 50%, then we can consider decreasing the MAP. So general principle is while weaning is the most toxic thing we have to wean off first. So most of the situation when we start as a failure of conventional ventilation, we'll be starting with 100% ventilation, 100% FiO2, because the baby is not maintaining saturation in conventional ventilation. That will be the biggest indication to start HFO. So once the baby is stabilized, we try to decrease the FiO2, and then next will be decreasing the MAP. Amplitude, we have to depend on the CO2. It cannot be clinically monitored. Clinically, we can optimize by seeing the wiggles, but for fine tuning, we'll have to depend on the CO2. Frequency, we don't fiddle unless we are not able to handle the CO2 with changes in amplitude. So once the baby is stable, the MAP comes down to maybe 10 or 9, FiO2 comes down to 0.3 and below, then we can consider extubation, consider switching to conventional ventilation. And subsequent weaning which will be similar that of a conventional ventilation. I hope we have already covered that part. What are the complications which is seen in high frequency ventilation? So sometimes the babies can have asynchrony and irritation. So sometimes we might have to give some amount of analgesic and sedation. If you don't take care of humidification, there is chance of secretions, and some complications like there is chance of hypotension, especially if you are giving too much MAP. So that can cause worsening shock. If the baby is fighting or if you are giving very high pressures, there is always a risk of pneumothorax. And sometimes there can be inadvertent hypocarbia. Like if you are not monitoring the baby frequently, any change in tidal volume is going to affect the CO2 removal too much. So recurrent episode of hypocarbia, especially in a preterm baby, we know can cause PVL and other complication. Sometimes there can be a chance of necrotizing bronchitis, especially if you are not properly humidifying, if you're not doing proper humidification. So coming to the conclusion, if you look at the evidence, this is a Cochrane review in 2016, where elective high frequency ventilation was compared with conventional ventilation. So in a total of 19 RCTs, including 4,000 plus babies, even though there was no effect on mortality, it decreased the incidence of BPD by almost 15%. And even the combined BPD and mortality was also showing a falling decrease. It also decreases the incidence of ROP by almost 20%. So even though there was a slight increase in air leaks, there was no effect on gross air leak. No effect on other parameters like IVL, PVL, and neurological outcome. So my take-home points is, whenever we are considering high frequency ventilation, don't consider it as a last resort when nothing else is working. It is better to put the babies on elective high frequency ventilation when we reach certain particular targets. For example, for a preterm baby, if the pressures PIP is going beyond 22 or maybe 25, we consider electively shifting to high frequency. Or when the MAPs are going beyond maybe 11 or 12, that is one indication. We generally, if you don't are not sure, then we can straight away start with a frequency of 10. But if we are having very small babies with weight less than 1.5 kg, then we may consider going at a higher frequency. In the beginning, we can set a MAP which is 3 or 4 above the conventional ventilation, and we can titrate the amplitude based on the wiggles, or we can on the vibration of the abdomen. So it should be visible till the umbilicus. Initial titration of saturation can be done based on the FiO2, but we'll have to depend on blood gas, chest X-ray, and other parameters to optimize the ventilation. So thank you. I come to the end of the talk. I'll be happy to take some questions, and we have Bejan sir is an expert in high frequency ventilation. So any questions, I am sure that sir will be happy to jump into. Thank you.
Thank you.
Thank you. Thank you.
Rohit. Thank you, Rohit, for your excellent presentation. I think Rohit has explained the mechanism of action of high frequency ventilation, what are the different types, and basically what he was talking mostly about high frequency oscillation ventilation, because in our clinical practice we are using SOHB. And one of the most important thing what he has highlighted, if we actually want to utilize high frequency oscillation ventilation, do not use as a last resort. That is what we were doing during our student days. Once a baby is dying, before the time of death, you just connect the baby to high frequency ventilation, you are not getting outcome results. That means selection of the case is very, very important. Unless you select your case carefully, you will be on the losing side. Second important thing is that some of the important points he has highlighted. Once you are using high frequency ventilation, there are two things, the two parameters you are very careful. One is map and second is the amplitude. And the map, the lung recruitment strategy, what he has highlighted. In all cases, it is not required, but nowadays we are also utilizing lung recruitment strategies basically in a baby with RDS where there is more atelectasis. Lung recruitment strategy means in the pressure volume curve to just increase the map, and when there is improvement in the saturation, definitely there is opening pressure. But after we will keep on increasing the map until it is the highest level. After that, if you increase further, then there will be peaking, you will reach the peaking part of the pressure volume curve. So once you get the peaking, then you come down. Once you come down again, then you come at the FRC level. That means with minimum map, you can get the maximum benefit. What we were not actually doing initially. We were just operating at the higher map level. In the last 2-3 weeks back, we had 2 patients. Initial map was there 18, 19, but we could come down to 7 or 8, 10 like that. What saturation you are getting with 18, the same saturation you might get about 8 or 10. So I think these strategies we should use. Unless you are using high frequency oscillation ventilation, then it is very difficult to make out what we are discussing. So the main important point is that if you want to use it early, not late. That means when you are failing in conventional ventilation, as he has said, that most people are using as a rescue mode, not as a primary mode of ventilation, because most of the evidences have shown that primary mode is as good as high frequency oscillation ventilation in most of the situations.
Yes.
I think there are some questions. We can take questions one after another.
Yes. So there are some questions on sigh breaths. I can see those. So
yes, sigh breath.
Sigh breaths is like it is like superimposed on the conventional ventilation. So you can imagine that high frequency ventilation is like we are providing a constant CPAP like picture, and on top of that CPAP we are providing oscillation. So this is the basic concept of a high frequency ventilation. But some ventilators allows us to provide a super added sigh breaths, like super added intermittent conventional ventilation. So for example, for baseline, we can equate high frequency ventilation as a CPAP or a constant PEEP on which we are providing oscillation. But suppose we are allowed to provide an additional conventional breath. So here we have a baseline PEEP and then we have some intermittent breaths. So that is known as sigh breaths. And typically these are like the frequency is typically maybe 3 or 5 per minute. And there we give a pressure which is, suppose on conventional ventilation, baby was on 20/5 or 20/6. In sigh breaths, that mechanical ventilation breath is given at a PIP of 5 above. So we'll maybe give at 25. And usually we keep a very higher TI, like because since we are giving only 5 breaths, so it is like a sort of sustained breaths. So what are the advantages that? So we have alveoli which are like recruited and they are vibrating in each high frequency ventilation. So by providing sigh breaths, one, it will help in recruiting some of the alveoli which are already not recruited yet. Second, some of the alveoli in the process of high frequency ventilation might get collapsed. So giving a sigh breath in between will prevent the collapse of these alveoli. So these are the two advantages of providing sigh breaths. So one is preventing the collapse of already recruited alveoli. Second is it helps in recruiting more alveoli, and thereby it can help in oxygenation also. So, sir, anything else?
I think we just nicely explained what is the cybrid. Cybrid is not available in many ventilators. In some ventilators like SLA 6000, they have got the cybrid. As you
Yes.
have rightly said, that means you are giving some conventional breath on the top of your high frequency oscillation ventilation.
Yes.
Even despite your high frequency oscillation ventilation, some alveoli may still be atlectic. And to open those alveoli, you give some higher pressure, like 15 or 20 centimeter pressure,
Yes.
like a conventional breath, with a maximum respiratory time, so that you are giving adequate time and adequate pressure to inflate those alveoli.
Yes.
But most of the time, we are not using this hybrid most of the time because high frequency oscillation ventilation mostly it helps us. But you can use in some very bad lung while we are or some outbound entrance, there is already there is attenuated alveoli, so you may get some help because of side. But side breath, as he has rightly said, it should not be more than 3 to 5 or maximum 6 or 10, because it cannot be just like 40 breath in a conventional ventilation. Your idea is that if there are some attenuated alveoli, with your side breath, those alveoli may open, there will be better gas exchange. The whole idea is that you open the alveoli and keep it open.
Yes.
Whatever ventilation you do, whether you do conventional ventilation or high frequency ventilation or CPAP, some of the alveoli will be collapsed, some of the alveoli will open during inspiration, and they will collapse during expiration. Normally, what happens in a normal ventilated alveoli, during expiration it will open, and during expiration it will not collapse. Some amount of alveoli will remain in the alveoli. Second time of alveoli may be there. During the time of inspiration, it will inflate, but during the time of expiration, it will collapse. That's like an RDS. Third type of alveoli is there. It may be collapsed both during inspiration and expiration. And our idea is that we have to prevent the collapsed alveoli during expiration to keep it open. And whatever alveoli already collapsed, we have to open it and keep it open.
Yes.
One saying is there, that is a saying, with a PIP you open the alveoli, and with a PWP you keep the alveoli open.
Keep it up.
So the mantra is that open the alveoli and keep it open, whatever ventilation you do.
Yes.
Any more question? Let us see. Another thing I think.
Question
if
are
we
there?
use,
No questions are written.
Okay. I think if we use volume current with high frequency oscillation ventilation, then the change of frequency will not cause any change in the tidal volume because your tidal volume is already fixed. So in that case, your frequency will not affect the CO2 number. It is a tidal volume, because the tidal volume is already fixed.
Yes.
Just let me ask the audience, how many of you are using HOPP? And so, don't worry if you do not use high frequency oscillation ventilation. With the conventional ventilation, you can get appropriate result. But one important lesson what we said, the selection of the cases and timed intervention is very important. Not only timely intervention and ongoing monitoring of the baby, because every time there will be changes in the mechanics of the lung. So, and we have to titrate the setting according to the need of the baby. So it is the baby who will tell you actually what should be done. So once a baby on high frequency oscillation ventilation as a clinical monitoring, you have to see the vibration. If there is no vibration, that means baby is not getting adequate MAP or amplitude is in the sort of washer. So clinically you see the vibration. And another important is do not go for frequent suction inhibition with high frequency oscillation ventilation. If it is not, you should not go for suction, but every time disconnect the baby from the ventilation, the alveoli will again go to the stage of de-recruitment. And if it goes into the de-recruitment stage, again you need to, it will take a long time again for it. So, is there any other question, any comments?
No, sir, I think.
You can directly ask if you are interested. You can take another 1 or 2 minutes if you can. Or otherwise, we will close the session. I think no more question is there. Thank you, Rohit, for your excellent presentation. Although the audience, I am sure many of the audience they are not using, but those who are using immediately, they will be benefited from your discussion. So more we discuss during our physical workshop on 12 and 13.
Okay.
Looking forward to a physical discussion. I think we have applied for leave.
Yes,
Looking
sir.
forward to see you. So one thing is that another question is there. Sir, one thing is told that we should allow the baby to breathe.
So what we meant by that is we should not completely knock out the baby or like give too much sedation or paralysis, because ultimately it will affect the weaning. So we need the baby to have some amount of spontaneous efforts. So only when the baby is fighting too much, then only we should consider, like routinely we should not paralyze the baby or give too much of sedations. So we need, like, that's what I meant to say.
So what Rohit is saying in our mechanical ventilation, whether you use conventional ventilation or high frequency ventilation, we have to allow the baby because most of the baby are spontaneously breathing. Some amount of effort is there because now the microprocessor based ventilator, they are using the babies, they are triggering the baby's breath. So if you actually knock down the baby, there will be no effort, even in conventional ventilation. Because just remember, even you ventilated baby, there is some amount of effort is still there. That effort is actually recognized by the baby, and that synchronizes the baby's ventilation, even in conventional ventilation. So one important lesson I think is a good question to ask. Whenever you are doing neonatal ventilation, never sedate the baby. Or you can give someone, let's say, if it is a bigger baby and baby is fighting, after controlling everything, if your ventilation is adequate, first, if a baby is not maintaining saturation or baby is fighting, baby is irritable, what the baby is telling us? Baby is telling us that support is inadequate. In that case, we have to optimize ventilation rather than giving sedation or analgesia. If you want to keep a baby for a prolonged period of time on mechanical ventilation, in that case, you may give some analgesia, not sedation, both during high frequency as well as conventional ventilation. Otherwise, as Rohit has rightly said, it will be very difficult to extubate the baby. So another question is Shomo is asking maximum map we gone up for newness. So he's saying what is the maximum map we can actually.
So generally we go up to maybe 20, 25, not beyond that, especially in
So
preterm
another
labor.
important, if you are increasing the map and still the baby is not improving, that means there is something seriously wrong with the baby. Baby is coming late or severe atelectasis, there is some inflammatory reaction, or there is some pneumothorax that we have to, there is some complication.
Yes.
So once you increase the map, definitely it will improve oxygenation. If it is not improving, we have to see other things also along with just by increasing the map.
Sometimes PPHN situation, it will not improve by simple recruitment. Most of them respond, but then we might have to consider INO in such situation also.
Yes. What Rohit is saying, support is PPHN, you can neither overinflate the lung or underinflation of the lung. If you overinflate the lung, it will compress the intra-alveolar vessels, and that will further increase the pulmonary vascular resistance. So if you are actually ventilating a baby for PPHN, you should operate at the FRC level where PVR is minimum. So how it is done with high frequency ventilation?
No, sir, that is about allowing the baby breathe. It was continuation. So we have answered that already.
Oh, that is the answer.
Yes, sir.
Any more question? I think there is
No
no other
questions.
question.
Yes, sir.
So if there is no more question, we can close the session today.
Yes.
Thank you, Rohit, once again for your excellent
Yes.
presentation. But it is an easy topic to talk actually, because most of us may not be aware of virus oscillation ventilation. Thank you Rohit, very much. Thank you all. Have a good night.
Good night.
You can
Thank you.
write
Thank you.
any question you have got, you can write in our group. Our speakers will be happy to answer. Thank you. Good
Thank
night.
you. Good
Thank you,
night.
everyone. Good night.